Assalam-o-alaikum. My name is Babar and I welcome you to my YouTube channel. Today we will study about difference between type 1 diabetes and type 2 diabetes. Second, clinical presentation of the diabetes. Gestational diabetes, area criteria for diagnosis of diabetes, treatment goals of diabetes, general approach of therapy, non-pharmacologic therapy. The first topic is difference between type 1 diabetes and type 2 diabetes. Type 1 diabetes occurs in childhood or adolescence and type 2 occurs when a person becomes adult. Type 1 onset is abrupt, type 2 onset is gradual. Type 1 have no family history, type 1 have family history. Type 1 patient have thin body type and type 2 patient have obesity. Type 1 patient have no metabolic syndrome and type 2 patient have often metabolic syndrome. In type 1, no antibodies are present, but in type 2, antibodies are present but in rare cases. In type 1, polyuria, polydipsia, polyphagia and rapid weight loss occurs, but in type 2, it's asymptomatic. In type 1, ketones are present at the diagnosis. In type 2, ketones are rare. In type 1, microvascular complications are rare, but in type 2, microvascular complications are common. Clinical presentation and diagnosis. The first one is screening. According to American Diabetes Association, screening for type 2 diabetes should occur every 3 years in adults that have age above 45 years. And the testing of type 2 diabetes should be considered in any adult regardless of their age who have BMI, that is basal metabolic index, greater than or equal to 25 kg per meter square. ADA does not recommend widespread screening for type 1 diabetes due to its low incidence in general population. But the people who have the more BMI, they should get screened for type 2 diabetes mellitus. Gestational diabetes. All the pregnant women who have risk factor for type 2 diabetes should be screened for undiagnosed type 2 at their first prenatal visit using standard diagnostic criteria. Any woman who is pregnant and is considered to be a diabetic, then the type of diabetes will be considered as type 2 diabetes and it will not be confused with gestational diabetes mellitus. All other pregnant women who have not currently known to have diabetes mellitus should be screened for gestational diabetes with the 75 gram oral glucose tolerance test, that is abbreviated as OGTT, between 24 to 28 weeks of gestation. Any woman who is diagnosed with gestational diabetes mellitus should be retested after 6 to 12 weeks of the delivery. If the screening results are normal at that point, then the reassessment of diabetes mellitus should be considered every 3 years to avoid any complications. Following is the criteria for diagnosing gestational diabetes mellitus with a 75 gram oral glucose tolerance test. In case of fasting, 92 or more milligram per deciliter sugar will be available in the blood. After 1 hour, 180 or more milligram per deciliter of plasma glucose. After 2 hours, 153 or more milligram per deciliter glucose is present in the plasma. If all these conditions are met, then the patient will be having gestational diabetes mellitus. Now move towards the ADA criteria for diagnosis of diabetes. ADA has mentioned 4 parameters. for diagnosis of diabetes in a person. The very first one is symptom of diabetes plus a casual plasma glucose concentration greater than or equal to 200 mg per deciliter. Now what is this casual plasma glucose concentration? Casual is defined as any time of the day without regard to time since the last meal. The classic symptoms of diabetes include polyuria, that is the more urination, polydipsia, the more thirst, and unexplained weight loss in the person, or FPG, the fasting plasma glucose greater than or equal to 126 mg per deciliter. Now what is fasting? Fasting is defined as no caloric intake for at least 8 hours. Number 3. 2 hours post-load glucose greater than or equal to 200 mg per deciliter during oral glucose tolerance test. The test should be performed as described by the World Health Organization using a glucose load containing the equivalent 75 gram of the anhydrous glucose dissolved in water. The fourth point is A1C, that is the glycated hemoglobin greater than or equal to 6.5%. The test should be performed in a laboratory using a method of National Glycohemoglobin Standardization Program that is certified to the Diabetes Certification Complication Trial. This table explains the categorization of ADA for glucose status. In case of fasting blood glucose, if the value of glucose is less than 100 mg per deciliter, then the person is normal. If the value is between 100 to 125 mg per deciliter, then the person will be having impaired fasting glucose. If the value is greater than or equal to 126 mg per deciliter, then the patient will be diabetic. Next is the 2-hour post-load plasma glucose, that is OGTT. If the value is less than 140 mg per deciliter, then the person is normal. And if the value is between 144 to 199 mg per deciliter, then the person will be having impaired fasting glucose. And if the value is greater than or equal to 200 mg per deciliter, then the patient will be considered as diabetic. Okay, now move towards the treatment of diabetes. For the treatment of diabetes, we will set goals that include reducing, controlling, managing long-term microvascular mean neuropathy, nephropathy, and macrovascular conditions mean ischemic heart disease, etc., and the neuropathic complications, preserving beta cell function, preventing acute complication from high blood glucose levels, minimizing hypoglycemic episodes, and maintaining the patient's overall quality of life. To achieve these majority of the goal, near normal blood glucose levels are fundamental, because if the glucose levels of the patients get higher, the condition of the patient will be severe. Two trials were developed. First is the Diabetes Control and Complication Trial, that is known as DCCT, and the United Kingdom Prospective Diabetes Study. These trials show that lowering blood glucose level decreases the risk of developing chronic complications. We can achieve a normal blood glucose level by educating the patient, changing the lifestyle modification, for example, maintaining or asking him for exercise, for taking proper food with low caloric intake and low glucose, and medications. For the proper care of diabetes mellitus requires goal setting and assessment of glycemic control. Self-monitoring of blood glucose, abbreviated as SMBG. Monitoring of blood pressure and lipid levels. Dietary and exercise lifestyle modification and proper medication use. Treatment goals of diabetes can be easily achieved if the patient and clinicians evaluate disease state control by monitoring daily blood glucose levels, A1C values, and estimated average blood glucose values, blood pressure and lipid profile of the patient. Self-monitoring of blood glucose is the standard method for routinely checking blood glucose level. SMBG enables patients to obtain their current blood glucose levels at any time easily and relatively inexpensively because SMBG can be done at the home without any problem to the patient. The A1C test provides weighted mean of blood glucose level from the previous 3 months, and this test should be done every 3 months if the patient is dependent on insulin. ADA recommends goals of therapy by analyzing the following parameters. The first one is A1C value. It should be less than 7% and evaluated after 3 months until the goal is achieved. And then if goal is achieved, then it should be retested every 6 months. Estimated average glucose should be less than 154 mg per deciliter. Preprandial plasma glucose means before meal or having meal. Its value should be 70 to 130 mg per deciliter, and the peak postprandial plasma glucose concentration means that after having food, its value should be less than 180 mg per deciliter. Blood pressure value should be less than 130 by 80 mm of mercury, and the lipid profile should be evaluated at least yearly so that patient can avoid any complication that often occur in cases of diabetes. Low density lipid profile should be less than 100 mg per deciliter or less than 70 mg per deciliter if the patient is at high risk. HDL profile, that is the high density lipid profile, should be greater than 40 mg per deciliter for males and greater than 50 mg per deciliter for females. The triglycerides level should be less than 150 mg per deciliter. After achieving these goals, the monetary complications are noted. For example, eyes. Dilated eye exam should be done yearly. Feet should be examined at least every visit because if a wound develops, it can cause complication and this leads to amputation of the organ. Now move towards the general approach to therapy. First we will discuss the general approach for type 1 diabetes mellitus. In type 1 diabetes, body requires exogenous insulin to replace the normal insulin function in the body because the pancreas of the body are non-functional, and insulin works to decrease the glucose in the body level. Ideally, insulin therapy mimics normal insulin physiology. The basal and bolus approaches are used to reproduce basal insulin response using intermediate and long-acting insulins. As a rule, basal insulin makes up approximately 50% of the daily dose. The remaining 50% of the dose is provided with the bolus doses around 3 daily meals. Now what is the bolus dose? Bolus dose is that insulin that is given subcutaneously to the patient before having meal. And the basal insulin are those that are given after the food is consumed. Exact doses are individualized to patient and the amount of food is consumed. Type 1 diabetes patients frequently are started on about 0.6 unit per gram per kg per day, and then the doses are titrated until the glycemic goals are raised. Mostly people use between 0.6 to 1 unit per kg per day. Currently, the most advanced form of insulin delivery is the insulin pump therapy. That is also referred to as continuous subcutaneous insulin infusion. These pumps are programmed to provide a slow release of small amount of insulin as the basal portion of the therapy, that is after having food, and the larger boluses of the insulin are injected by the patient to account for the consumption of food, and it is given before food, almost 30 minutes earlier before having food. Pramlintide, a synthetic analog of naturally occurring hormone amylin, is a injectable blood glucose lowering medication that can be used with type 1 diabetes patients and type 2 diabetic patients using insulin for treatment. Now move towards the type 2 diabetes. Treatment of the patient with type 2 diabetes has changed due to addition of number of new drugs and the recommendation of ADA to maintain tighter glycemic control. Lifestyle modifications such as education, nutrition, exercise, and having medication on time are the basic need to manage the disease successfully. There is a misconception that people think if the patient with type 2 diabetes mellitus have initiated the pharmacologic therapy, then there is no need for lifestyle modification. This is absolutely wrong. Because type 2 diabetes mellitus generally is progressive in nature and the blood glucose level can increase instantly and making the patient insulin dependent, and the modification of lifestyle are the basic requirement after that problem. Now move towards the gestational diabetes. In pregnant women, it is recommended that the pregnant woman should have at least 3 meals and 3 snacks per day. Preventing ketosis and promoting adequate growth of the fetus, maintaining normal blood glucose level, and avoiding undesired gastrointestinal side effects are the desired goal in the gestational diabetes mellitus. Controlling blood glucose level is important to prevent harm to the fetus. An abundance of glucose causes excessive insulin production by the fetus. If left uncontrolled, can lead to the development of abnormally large fetus. In case of GDM, if the blood glucose levels are not controlled during the pregnancy, then it can result in infant hypoglycemia at delivery, hyperbilirubinemia, and some other complications at the delivery of the baby. Those people who cannot maintain the normal target levels of glucose by diet and physical activity, then insulin is used. In women who develop gestational diabetes and cannot control blood glucose level with lifestyle modification, then insulin Datimer, insulin aspart, Lispro, and regular insulin can be used with the category B safety ratings. There is a popular notion that there is no diabetic diet, but medical nutrition therapy is considered as integral component of diabetes management. People with diabetes should receive medical nutrition therapy preferably by a registered dietitian who can guide them about their meals and having nutritional values. As part of diabetes management plan, medical nutrition therapy should not be a single education session but rather ongoing dialogue with continuous visits of the patient at the doctor's clinic. Medical nutrition therapy should be done according to the cultural, lifestyle, and financial consideration of the patient. Medical nutrition therapy should include a variety of food that the patient can easily enjoy and so that he can improve his adherence. During the medical nutrition therapy, Patient is given instruction about their food selection and their preparation, portion control of the meals, and their use at the proper timings. The primary focus of medical nutrition therapy is the matching of optimal insulin dosing to carbohydrate consumption. Now, types of medical nutrition therapy. American Diabetes Association has issued recommendation for three types of medical nutrition therapy. First one is the primary prevention. Primary prevention measures the medical nutritional therapy are directed at preventing or delaying the onset of type 2 diabetes in high-risk individuals that are obese or with having prediabetes by promoting their weight reduction. The secondary prevention measures of the medical nutrition therapy are directed at preventing or delaying diabetes-related complications in diabetic individuals by improving their glycemic control. Number 3. Tertiary prevention. The measures of tertiary prevention are directed at managing diabetes-related complications that are cardiovascular disease, nephropathy in diabetic individuals. The glycemic index is the estimate of the postprandial rise in the blood glucose when a certain amount of specific food is consumed. The foods with low glycemic index can improve the glycemic control because they have low glucose values in them. Normally, fruits, vegetables, fiber-containing foods, and low-fat milk is advised to patients with diabetes. Reduced caloric intake and non-nutritive sweeteners are useful. Currently, there is no evidence of supplementation such as vitamin and antioxidant and micronutrients in patients with diabetes. Dietary supplements. Some of the dietary supplements can be used for improving glucose control. That are the Coccinia indica and American ginseng. Some other supplements can also include, for example, Gymnema sylvestre, aloe vera, Memordica chirantia. Last topic is the weight management. Moderate weight loss in patients with type 2 diabetes has been shown to reduce cardiovascular risk as well as delay or prevent the onset of diabetes in those with pre-diabetes because weight has a very important link between the disease and person's health. The recommended primary approach to weight loss is therapeutic lifestyle change that include almost 7% reduction in weight loss and increase in physical activity. Slow but progressive weight loss of 0.45 to 0.91 kg per week is preferred in those patients who are diabetics. That's all for today. Next lecture will be on pharmacotherapy of diabetes. If you like the video, then subscribe the channel and press the bell icon for more updates.